Good afternoon to all of you. I welcome you all in post-lunch session. Now I invite the chairperson for the session 3, Dr. Piyush Rai. Dr. Piyush Rai needs no introduction to the audience. He is a very dynamic and very aggressive interventional cardiologist. Dr. O.P. Tiwari sir is a president, former president of IMA Varanasi, former president API Varanasi, and secretary of IMA Uttar Pradesh, president IMA Uttar Pradesh. Is a very senior physician. And Dr. Mohit Saxena, I think he is not here. Dr. Arup Das Gupta, he is a young dynamic physician. He is a very good biker also.
चलो
And
अच्छा इधर आ जाओ तुम अब यहाँ जगह
I also invite Dr. Akhilesh Singh.
लास्ट वाली
He is a very senior physician and very
और
close friend
छोटा
of
बच्चा
mine
तुमसे भी छोटा
and my batchmate as well.
नहीं
हमसे छोटा तो उसमें मुश्किल है
Now I request chairpersons to conduct the program and invite the speakers.
Now, post-lunch session, we have eminent speakers and very interesting topics to carry forward this seminar. Now, I would like to invite Dr. Ashutosh Marwah, who is director in pediatric cardiology at Escorts, and he is going to talk about the management of congenital heart disease in adults. Marwah, sir.
Thank you, chairpersons, and thank you, Dr. Alok, and all the organizers. Yeah, I have been given the task of talking about management of congenital heart disease in adults. It's a vast topic, and I'll try to do justice within the time provided to me. So, we know that there are lots of adults with congenital heart disease, and global burden is about 8. For congenital heart disease is about 8 to 10 per thousand, out of which 12 per thousand are only mild diseases, where 3 per thousand are going to be the severe varieties. And with the latest surgical techniques and managements, majority of these patients are going to reach adulthood. And global burden of adult CHD is considered to be around 50 million, and it's going to increase. And in some countries, the adult CHD is actually outnumbering the pediatric CHD. In India, we do not have the real figures, but it is estimated that about 3.5 million people live in India. Most of them are unrecognized and are vulnerable group. We do not have a defined adult CHD program in India. There are no surveillance programs, so there is lack of infrastructure and there is lack of information. ACC guidelines recently and European guidelines in 2020, they have classified adult CHD in 3 main categories: mild variety, repaired congenital heart disease without any residual sequelae, which would be very simple heart disease such as ASD, VSD and PDA, then isolated bicuspid valve, mild PS, isolated mitral valve disease, etc. and hemodynamically insignificant VSD or PDA. Then comes the moderate varieties, which are repaired or unrepaired conditions such as TAPVC, aortic stenosis, Al-Kappa, ASDs, VSDs, which have significant shunt but are operable, coarctations, post-operative tetralogies, TGAs, etc. Then are the severe varieties, which include repaired or unrepaired conditions such as cyanotics, all TGAs, post-arterial switch, double outlet right ventricles, univentricular physiology. So these are increasing degree of complexity. And Eisenmenger syndromes. Then we have the functional classification, which is similar to what we have NYHA classification. Functional class 1 with no hemodynamic or anatomical sequelae and normal exercise capacity. Functional class 2, mild sequelae, say mild aortic enlargement, mild ventricular dysfunction, mild valvular disease, say mild AR or MR. Arrhythmia not requiring treatment, so occasional ventricular ectopics, etc. Then class 3, where we have moderate aortic enlargement, moderate valvular disease, or a hemodynamic significant shunt, still amenable to repair pulmonary hypertension, but it is less than severe and responsive to treatment, and end organ dysfunction may be there, but it is responsive to therapy. And severe NYHA class 4, which means severe aortic enlargement, arrhythmias, hypoxemia, end organ damage, and Eisenmenger syndromes. So with this broad classification, we move ahead. We look at when we see a patient who is adult CHD, so how do we decide? So it's very important to have a complete anatomical and hemodynamic assessment. We need to understand the functional class, and if there has been a sudden deterioration, adults will often have associated comorbidities such as hypertension, hyperlipidemia, diabetes, etc. And another important thing is one has to understand the natural history of the condition, and wherever there is a need for evaluation, one may have requirement of a pediatric cardiologist who understands the lesion. So for evaluation, we have standard things: echocardiography, ECG, Holter, cardiac CT, and MRI. Cardiac catheterization is rarely needed except for when we are planning the intervention. Adult congenital heart disease patients, they have multiple problems, and the common problems include congestive heart failure, arrhythmia and sudden death, pulmonary hypertension, cyanosis. Then we need to have understanding of pregnancy, contraception, non-cardiac surgeries, coronary artery disease, and other age-related morbidities. And another important thing is infective endocarditis and its prevention. Congestive heart failure is the commonest problem. It's occur in at least 26% of adult survivors, so 1/4. And 1 and 3 year mortality after first admission is very, very high. So if you look at figures, almost 1/3, that is 35% patient may die at risk of mortality after first admission. And 8% patients will experience sudden death, and majority of them are occurring during rest. So congestive heart failure actually is, if you can say, is a harbinger of what we tell us, okay, fine, this patient's life is at risk. And it is difficult to identify and it is difficult to treat because they are not normal hearts. These patients have always been compromised, so they really do not understand what was, when they are going downhill, probably they understand it's okay, age related. So common factors that we see as there's a reduced exercise tolerance, cachexia and weight loss may be there. Some patients with tricuspid or right-sided heart failure can present as liver failure and ascites, and it is not very uncommon to see patients who come to you as ascites and liver failure, and then you realize this patient has an Epstein's or another form of tricuspid heart problem. Pedal edema and pulmonary edema generally late features of congenital heart disease, whether repaired or unrepaired. Treatment options, sorry for this congested slide, but are also limited because what we see is mostly trials have been done on patients with 2 ventricles. But these patients are different, but still we can try for biventricular patients standard therapies such as Lasix, renin-angiotensin system, ARBs or ACE inhibitors. But what about patients with single ventricles or dominant RVs, post-Sennings, or patients with tetralogy or with free PR? So there, all these drugs, diuretics, ACE inhibitors, ARBs, probably do not work for very long. They may be able to control the symptoms, but there is not enough data supporting their use for long term. And very often we realize when we put the patients on ACE inhibitors, their cardiac output drops, they become hypotensive and they become more symptomatic. So one has to adjust the dosages. Maybe from standard dosage we would like to go on to very minimal dose and gradually build up rather than start with a maintenance dose straight away. Again, there is not enough data on sacubitril valsartan in adult CHD. Wherever possible, so here comes the important thing, wherever possible, identify the culprit lesion if there is anything that is rectifiable. So treat arrhythmia, treat valvular incompetence or valve obstruction, or if there is a residual shunt which has now become significant, you close that shunt, and most of the time these patients may become better. So residual VSDs and PDAs which were considered insignificant during infancy or childhood may require closure when patients become adult. Similarly, pulmonary valve implantation may be needed in adult repaired tetralogies with free PR. Cardiac resynchronization therapy has role in CCTGAs. End-stage patients may benefit only with heart transplant. And mind you, there is not only heart, sometimes they may need heart and lungs or heart and liver, so they may have higher morbidity and mortality. Second big problem that we face is arrhythmia, and I must say arrhythmia and CHF go hand in hand. And if more than 50% patients are going to develop arrhythmia before the age of 65. Potential factors causing are myocardial fibrosis, scarring. They may have anatomical substrates such as CTGA or heterotaxy syndromes. Atrial arrhythmias being more common, and the incidence keeps on increasing with every passing decade. And they cause increase in morbidity, fourfold increase in risk of CHF, and increase in mortality, twofold increase in risk of death if untreated or not picked up in advance. Similarly, ventricular arrhythmia occurs from monomorphic non-sustained VTs to polymorphic. Monomorphic are usually related to ventricular scars, but polymorphic VTs tend to occur more with ventricular dysfunction, and they will only require probably cardiac transplant. So, rule is to rule out reversible causes. There may be hypothyroidism or inflammatory process. If patient with tachyarrhythmia is presenting within 48 hours, atrial arrhythmia, especially cardioversion, delayed presentation, look for clot, pharmacological management and oral anticoagulation. Chronic antiarrhythmic therapy, again in dilated hypertrophic ventricles, can have cause ventricular dysfunction in long-term use, and especially amiodarone should be avoided for long-term. So catheter ablation, if possible, should be considered, and it is now class 1C. Implantable defibrillators may be considered. There is not enough data, so again it is case by case, and it's again class 1C indication. Another thing which is very common is pulmonary hypertension, whether operated or unoperated. PH is seen in almost 3.2% of CHD patients, and common risk factors include late presentation or first time presentation in adulthood, delayed repair, Eisenmenger, Fontane's, abnormal vascular beds, etc. And this is the table that comes from European guidelines. We have now they say mean arterial pressure, mean PA pressure more than 20 should be considered as pulmonary artery hypertension. We need to differentiate between pulmonary hypertension because of pulmonary vascular bed and the left-sided disease, because the management would be different. Patients with pulmonary hypertension because of pulmonary vascular bed will respond to endothelin receptor antagonist, whereas for left-sided disease we will require to give management such as diuretics or ACE inhibitors. Wherever possible, one should try and close the shunt if possible, and closure of shunt is only recommended in patients where PVR is less than 3 and shunt is still more than 1.5:1. This is class 1B. Wherever possible, as discussed earlier, device closure is method of choice, but if you are closing ASDs in adults, surgical treatment is needed, then one should clearly evaluate risk and mortality benefits, and it remains the class 1C indication. Patients with PVRI between 3 and 5, QPQS more than 1.5, we could still go in for closure of the shunts, class 2A indication. Wherever PVR is more than 5, we cannot close the shunt lesion. They need to be put on treatment for 6 months of pulmonary vasodilator therapy, reassess them, come back, and if PVR drops to less than 5 Woods units, QPQS is more than 1.5, closure may be recommended. But again, there is no prospective long-term trial data available for this treat and repair approach. This does not guarantee a long-term drop in PVRI, so fenestrated ASD closure may be the procedure of choice. And patients may, as I said, if you just close the lesion, patient may worsen and become PAH, primary PAH, and they have poor outcomes. So in general, we prefer to put them bosentan and phosphodiesterase. There is a limited data available on macitentan. Routine use of anticoagulation is not recommended until unless patient is having atrial arrhythmias. So warfarin and acitroms are drug of choice. There is no recommended data available for use of newer oral anticoagulations. Another important thing which I would like to point out is pregnancy, because as these patients are growing older, there are many women who would like to have children, But again, these are at-risk patients, and maternal mortality is very high, 1% and 11% risk of developing CHF. There is a higher incidence of preterm labor, pregnancy-induced hypertension, and postpartum hemorrhage. In a study where patients have SpO2 less than 85, say unrepaired conditions, very high fetal mortality and live births are only seen in less than 12% patients. Women with PH should strongly be discouraged pregnancy. They have more than 58% preterm births, 12% mortality. So yes, this is a very high risk group. And there are also fetal risks because of maternal medications, especially ACE inhibitors, which cause renal malformation, oral anticoagulation, which risk the fetal syndromes, beta blockers can cause small for gestational age, fetal hypoglycemia, and yes, risk of congenital heart disease to be getting transmitted into the next generation. So fetal echo is very important, and I have listed the lesions where there is a increased risk of transmission, say ASD. Risk is 4 to 6%, coact 4 to 6.5, tetralogy 2 to 2.5 for next progeny. So one has to carefully monitor these children. Pregnancies should be screened for occurrence of congenital heart disease, and patients should be counseled accordingly. These are the class of mothers who are very high event rate, 19 to 27% mortality, unrepaired heart disease, LV impairment, systemic RV, Fontan circulations, asymptomatic AS, which is severe because once the cardiac output increases, these patients are going to become symptomatic. Moderate mitral stenosis may become severe mitral stenosis and will require balloon dilatation during second trimester. Marfans and coacs are at risk of rupture. So all these patients have to be monitored closely. Extremely high risk, where very high event rate, pulmonary hypertension, severe, if I would like to take a few more minutes please, severe LV impairment, systemic right ventricle, they should avoid pregnancy, and wherever possible, say congenital severe mitral stenosis or aortic stenosis should be treated well in advance before the lady wants to get pregnant. So multidisciplinary approach is required. There should be a contingency plan for mother and the baby both, because the pregnancy may end up early, so preterm delivery may happen. Length of pregnancy and mode of delivery should be carefully planned. Termination should be discussed, especially if the pregnancy is considered high risk and there is high risk of maternal mortality. Advice regarding contraception and should be given to all the couples. Barrier method is preferred, followed by progesterone only. IUCDs are there, but they increase risk of endocarditis. So in the end, I would like to say congenital heart disease is a lifelong condition. It starts in the fetal life and it requires care up to the adult age. Most of these patients will live well, but they tend to have shorter lifespan than normal population. There is increased risk of malignancy, neurocognitive disorders. Even the pulmonary circulation is not spared. They have pulmonary hypertension, reduced lung volumes. Many patients also have chronic kidney disease. There is a risk of acute kidney injury, hepatopathy, and acquired liver disease. So it's not just the heart, but congenital heart disease is a multi-system disorder, and as the patients get older, we need to look after them better, and many times it's just pediatric cardiologist is not sufficient, so we need to create teams between adult and the pediatric cardiology. So good services are now required in this hospital. Thank you.
Thank you, Marwah sir, for insightful lecture. And now we can have some questions from the audience. So, sir, in our practice we see a lot of unrepaired shunt lesions. So, suppose a person of around 30s comes with the first time detected shunt lesion. So, approximately how many percentage of these patients are unable to shunt closer?
So it depends what shunt are we looking at. Are we looking at a pre-tricuspid, that is the atrial level shunts, or are we looking at VSDs or PDS? So ASDs can be very deceptive. Right-sided cardiomegaly doesn't tell you anything. You have to look for features of pulmonary hypertension, TR values. If TR is more than 50 or half systemic, you would want to catheterize this patient to make a plan. Even if it is deviceable, probably it is good idea to have a two-stage thing, have a hemodynamic data, and then see if the PVR is low, go ahead for the device closure. Similarly, for large VSDs, anyway, large VSDs are inoperable if they have reached their adulthood. Most of them would be probably Eisenmengerized. General rule of thumb is even if the patient is pink, say saturation is 90, though we say that less than 85 is inoperable, but if the saturation is 90, you could just make a patient do some exercise in your room, make them do some sit-ups or just make them do brisk walk and recheck the saturation. And if the saturation goes down, most of the time this patient has become inoperable. Same thing for the PDA. Look at the saturation for upper and lower limb. Upper limbs are not going to be blue. Look at the saturation in the lower limb. Check for the hemoglobin. If the patient has bidirectional shunt, invariably they will have polycythemia, the hematocrits will be high, the hemoglobins will be high. These are certain indirect markers. One can go for an X-ray, you could do a formal cath, but indirect markers, you know where you stand. Whereas moderate shunt, say moderate VSD or a PDA, where assessment is done by the echocardiography, you have features of LV enlargement, you have pulmonary vascularity on X-ray. The shunt is still persisting and there is left to right shunt on echocardiography and Doppler. There is a continuous murmur of PDA, and these patients will be safe for doing a device closure or surgical closure as the plan may be. Mind you, very important things, large PDA, though traditionally we started doing balloon occlusion test of the PDA, and we would go in for PDA device closure on the same table, put the device and come back if there was a drop in pulmonary artery pressure by 50%. But to be surprised, most of these patients never actually developed regression of pulmonary artery pressures. After a few days, their PA pressures will be 70s and 80s. So probably that strategy is wrong, and now ECSI guidelines actually warns against it. So now they're saying that only basal hemodynamic data should be considered. Reactivity to oxygen or test occlusion does not guarantee a successful drop in pulmonary artery pressure. So that's how we look at it now.
So, if I'm allowed, Marwah, interesting, very fantastic talk. I got one question with you in the light of ESC guidelines, which is more than 20 mean PA pressures, significant pH. So how would you today would approach a 35-year-old patient with very large ASD, almost common atrial,
Yeah.
around 3 qpqs? They will have high PA pressures. They may have gradient across pulmonary valve around 20, something like that. So are we RA volume overload? You got 3 qpqs. What will be your approach in today's time?
Today's time, I would not do anything. Look at the basal saturation. If you're saying common atrium, they may be pink or they may be blue, depends on what we have. So basal saturation, if above 85 or 90, close to 90, I would take this patient to cath lab. Most important is to do a hemodynamic data, get the SVC, PA, aorta, pulmonary vein saturation. There's a ASD. You can get a pulmonary vein saturation, do the calculation QPQS, see what is the calculated PVRI. If it is less than 5, ideally less than 4 or 3, but if it is less than 5, you could do a ASD closure. If it is less than 3, close it completely. 3 and 5, leave a small fenestration, 5 millimeter, 6 millimeter if you're going for surgery, or put a fenestrated device if you're going for a device closure. One can always come back and close that fenestration later, but do not close it immediately. And if any patient, I'll tell you this is 3 days back, this lady is 46, comes to us, primum ASD. On the face of it, TR value was 40, but still she's 42 years. So we take her to cath lab. I was surprised her PA pressure was 70, systolic, whereas arterial pressure was 130. We tested, PVRI calculated was 5.8. On room air, then with vasodilator, oxygen and nitric oxide, the PVRI dropped only to 5.3. So testing is important, and now at 5.3, we have decided to wait. We're going to put her on therapy for 6 months, call her back again, check again after 6 months. If the PVRI is low, we will do a fenestrated closure. So it's important to have the baseline data, to have, one could do a vasoreactive testing if easily available. Now they say this, it has not much role, but we still do it, oxygen and nitric oxide both, or nitric oxide alone, and see if there's any reactivity still.